Actually, I'm not becoming restless. I'm enjoying Prashant Bobade's talk and also your discussion.
Just kidding
I
you.
think fortunately you have. Just kidding you. Neeraj Avasthi did not come, and hence I think we probably had a 15-minute time extra, right?
Correct.
Absolutely correct,
Okay.
Shiva.
So now let me, if you have time now, I'll start the PowerPoint. One of my colleague will discuss this case. This is a very interesting hemodynamic rounds that we are going to do now. Start the PowerPoint.
So the first case is the 7-month-old boy. He was born at term with firstborn of third-degree consanguineous marriage by normal vaginal delivery with a birth weight of 2.6 kg. And antenatally detected to have small RV with pulmonary atresia. On day of life 1, the baby was referred to Triple M Hospital with saturations of 65%. 2D echo done showed hypoplastic bipartite RV with hypoplasia involving trabecular region. There was intact interventricular septum with unobstructed RVOT and confluent adequate size branch pulmonary arteries. There was a 5 mm PFO shunting right to left with mild PH and a closing PDA. There was a ductal stenting attempted at day 1 of life. However, it could not be done. So then later on, baby was kept on regular follow-up, maintaining saturations around 80 to 85%. In view of preserved antegrade pulmonary blood flow and child remaining relatively stable, interventions were deferred. So on examination now, currently the baby has poor growth with height of 115 centimeter between 3rd and 10th centile with a weight of 15.5 kg, which is less than 3rd centile. Saturating 85% on room air with central cyanosis, grade 3 clubbing, and polycythemia with hemoglobin of 15.2. The cardiovascular system examination S1 is normal with normal split and no murmur. This is the X-ray of the child with situs solitis, levocardia, CTR of around 50%, dilated RA and left arch. The ECG shows a normal sinus rhythm with a QRS axis of 0 and normal LV forces. This is the echocardiogram, which shows again there is a mild RV hypoplasia involving the trabecular region and with adequate sized LV and mitral valve. This was the Z-score. The tricuspid valve was 18 millimeter with a Z-score of minus 0.25 and mitral valve of 23 with a Z-score of plus 1.31. This is the PFO, which has been shunting bidirectionally, both left to right and right to left shunting, and measuring around 5 millimeters. This is the current, the oximetry and hemodynamics which we have done now. And with the aortic saturation of 84.8, that is 85%. There is SVC and IVC. SVC is 56 point. There is no step up. And however, there is a step down of 11.5% from PV to aorta. The RA mean is 8, which is normal. And there is no gradient between RV to PA, and PA pressures are 20/5 with mean of 13, normal PA pressures.
Over to you.
Yes, please. So can you hear us now?
Yeah, we can hear. Shiva. Yeah, we can hear.
Okay. So the story of this patient. Show the PowerPoint, the last hemodynamic page again. Get the PowerPoint on. Okay. So this was just now done, about like 10 minutes before. That was the reason why we wanted another 15 minutes and we requested Prashant to give the talk. The superior vena cava saturation is 61, IVC is 56, mixed venous is about 59. There is no step up at all. But there is a significant step down from 96 to 84. And as I speak, the saturation in room air for the boy in the pulse oximeter is varying between 82 to 86. The story is that it's a borderline hypoplasia of the right ventricle, borderline hypoplasia of the tricuspid valve with a tricuspid Z-score of I think minus 0.3 or minus 0.4 or something. So the question is, should this patient go for a bidirectional Glenn shunt plus ASD closure, which means it is 1.5 ventricle repair, or should the patient go for a primary ASD closure with allowing the RA and RV to be overhauled by the additional flow of the systemic venous. Now the systemic veins are predominantly 50% of the blood is actually going through the PFO into the left atrium and LV, whereas if you close the ASD, will be driving the blood from the RA to the RV. So the question is this RV adequate? That's the question that we need to ask. So while this is going to give you a lot of ideas to think about, quickly Pramod will show some echocardiography, live echocardiography. So show echo big. Echo big.
Sir, did you check the RA pressure?
This is the 4-chamber.
Sir, did you check the RA pressure?
Everything. No, actually the hemodynamics was just shown a short while ago. I will again show the PowerPoint once again. I'll show it once again.
Yes,
Okay.
we are here. Yeah, we are here. This is the echocardiography. It's a transthoracic echocardiography. This is a apical 4-chamber view where we can see that the left atrium and left ventricle and right atrium and right ventricle. The right ventricle is actually tripartite only. It has an inflow, it has an apex, and it had an outflow that I will show here.
No, show serially. It's okay.
Yes, sir. It had an outflow also. So it's a tripartite RV, and it is definitely hypoplastic. But how much is the significance of his hypoplasia? We are going to evaluate now. This is the ASD. It's in a subcostal view, where we can see that this is a small PFO, which is shunting predominantly right to left, as we can see here. We did a
No, second, fourth picture.
Fourth picture. Okay.
Go in order.
Yes, sir. This is again the subcostal view where we can see the PFO. This is the same thing with predominantly right to left shunting ASD. This is the tricuspid valve, which is mildly thickened, but it is moving normally. And this is the contrast echo we did just now, which shows that the contrast is moving into the LA and LV, and it's having almost equalization of contrast in the RA and in the there is equalization of contrast in RA and RV and LV when we see in this.
Okay. Now show the hemodynamics big. I'm just showing only the right atrial pressure. A tall A waves of about 10 millimeters of mercury and a mean pressure of around 7 millimeters of mercury. And what you see down 87% is the room air saturation at present. Now in the clinic when I saw the boy, the saturation after a little bit of play and activity drops down to 70. So this is where we are now. So I would like to ask the panel about what you would like to do, how to approach this patient.
Did you do the balloon occlusion of the ASD?
Give me RA, Bobby.
Did you do the balloon occlusion of the ASD?
Okay, I'm going to do it live for you. Before that, I have not done it so far. I'm going to do it live, but before that, I just want one RV angiogram, because Pramod told that there is a tripartite RV, and the Dr. Fareen told that the tricuspid valve Z score was almost RAO30 was almost like minus 0.3. I want to get an objective one mag objective opinion about what is the size of this right ventricle. 15 at 15 ready? Okay. So this is the size of the right ventricle. The hemodynamic page once again, PowerPoint. Show the PowerPoint once again, the hemodynamic page alone. Yeah. See the aortic, the RA mean was around 7. The LA was also the 7. LA and PV were also 7. RV was 20 and PA was 20 by 5 with a mean of 13. And aortic pressures were about 100 over 60. Aorta was desaturated to around 85%. Now as I talk to you, it is 83%. So I take Dr. Sushil's views that balloon occlusion should be done. What are the other person's views?
I think you should do the balloon occlusion, of course, but RV doesn't look bad on the angiographically.
Okay.
Angiographically,
Okay. Okay.
definitely it looks like tripartite, though it's a two-dimensional view. A tripartite ventricle.
Yep.
Now,
Yeah.
Dr. Nageshwara is asking Z-score tricuspid is
We
minor.
know that
Nageshwara is asking Z-score tricuspid is
minus 4, I think.
No, minus 0.25.
Minus 0.25.
I think these are the some of the cases PAIVS will have chronic diastolic dysfunction. So that is the reason
Yeah.
they tend to have this. So our approach is
Okay.
yeah. Our
Actually, it's
approach
not
is to
PAIVS.
reduce the size of the AST. So 5 millimeter. Okay, he is demonstrating.
Yeah, the Nageshwar, it is not PAIVS, it was a hypoplastic right heart syndrome.
Okay.
With,
No,
with
I
the
was not there.
antegrade
Sorry for
force
that.
through
I
the
was not
RV and PA.
there. Okay.
Yeah. So right now what we are planning to do is do possibly a small balloon occlusion. I want a 10 into like 12 into 3 tie shack balloon. Twelve four. The smaller the better, because we will not be occupying too much of space in the RA and LA. Check whether we have a 12 into 3 tie shack.
So to understand, this is a case of an isolated hypoplastic right heart syndrome, the borderline RV, if I am correct.
With a borderline, yeah, with a borderline RV and exclusively right to left shunting ASD with no left right shunt.
Okay.
No step up in the oxygen saturation from mixed vein to PA, but significant step down of 14% from the pulmonary vein to aorta. Only right to left shunting, no left right shunt. Get me a contrast.
So while we are doing that, hemodynamics is doing, the treatment options are interesting here. A baseline cardiac cath, what Dr. Sivakumar is showing, that test occlusion, first do the bubble contrast echo, test occlusion, check the RV EDP and all other pressures. If it is a large defect or moderate defect, reduce the size of the AST either by transcatheter or by surgical method, or offloading the right ventricle by doing the Glenn and closing the AST based on the hemodynamics. These are all various options, but the most important thing is what he is showing, demonstrating the hemodynamics are
Put it
essential.
on, put the RA pressure big, RA pressure big, RA pressure big. So right now what I have done is, I have occluded the ASD.
Okay. So is it the
And I am going to now do,
the pressure is how is the pressure being monitored now? Is it a catheter is in RV?
the sheath is in the inferior vena cava. I will show you the sheath now.
Okay.
Almost you can see the sheath now.
I can see that.
It's
yes.
inferior vena cava.
All of us should
Yeah.
understand the
I
standard
want
form
a-
of
I
therapy
want a three-way.
is bidirectional Glenn ASD closure is a 1.5 ventricle repair in this case. But Shiva is trying to explain to us whether some other alternative
So
can be done.
can you actually run the RA pressure little bit faster speed so that we can see the A and the V wave?
Faster speed, RA
It looks
faster
like
speed.
it is a V wave is dominant, but I can't figure out. Maybe you are seeing that directly.
A wave.
A wave, yeah.
A wave is
Obviously, A
prominent.
wave only will be dominant because it's a non-compliant right ventricle. It's only the restrictive physiology, so that A wave will be prominent. So whatever the dominant A wave, you can see that just prior to the QRS, which is coming, A wave is the dominant. Just on the.
So what we are finding is that I am not getting an elevation of the RA pressure. Now I am giving contrast echo. Open the RV as much as possible, Prabhu. Make the echo big. Echo big. Yeah. So now I am giving a contrast echo. Little bit of spillover is there. Let me see whether I can completely occlude the PFO. I'm giving more contrast, Pramod.
Yes, sir, 1 second, sir.
Get the LALV as much opened as possible.
One second, sorry.
Are there any other additional perforations or anything? Fenestration?
We are looking at that. I am not getting a saturation climbing up.
Maybe a
Pramod, I want
transesophageal
a
echo is
proper
essential.
good four chamber.
Maybe a transesophageal echo is essential.
Get a
Subcostal. We'll go to subcostal
pediatric
have,
TE probe with a with I33 inside. Okay.
Yeah, we'll go for a
Now
subcostal.
it's much more vigorously filling.
I think there is an additional defect. It's a good idea what you are trying to do a pediatric TE probe and all. Let us see that the defect.
Yeah.
Go sub-
LA is filling.
Okay.
First is
Prabodh,
LA.
obviously, this is no, not first LA. First RA is filling. I'll show you.
No, for RA to LA. LA is also filling. For RA to LA.
Yeah.
RA to LA. Yeah, RA to LA. Correct. So atrial communications are not getting obliterated by this bulb. Show this apical four chamber.
Yes, sir. 1 second. Sir, I'll go to subcostal and have it. Subcostal windows are good.
Which is a
Okay,
good thing
now
for
I'm-
the patient, no sir? Which is a good thing for the patient. If all the
Which
ASU are
one?
not being closed, we could close one of them in this non-conventional approach.
Actually, Dr. Rita, I have a completely different idea.
Okay,
The
sir.
patients, this particular child is prone for prolonged hypoxia with reduced effort tolerance.
Yes, sir.
Is prone for polycythemia and polycythemia related complications. Is prone for paradoxical embolism. So in every patient where the right heart is reasonably able to take the load of the systemic veins, we should allow the systemic veins to go through the pulmonary artery and not allow a right left shunt. Risk of paradoxical embolism plus risk of Pramod, I have not deflated the balloon,
Oh, okay, but
For the-
so I have gone through some other
some
hole.
other hole. Actually, this is still here.
Pramod, what is happening is sometimes the color, no, whenever there is a right to left shunt, your eyes will not catch the right to left shunt. That's why if you invert the color, you will see the
I
shunt
want-
better in subcostal
I
view.
want
So
I want,
you put it
yeah,
and
to
you
recross
put a
now.
color and invert it. Can you invert the color?
Inverted.
Actually, now you can see that
Yeah,
the
we can
PFO
see
is
it now.
actually totally open, and I have gone through some other communication.
Absolutely.
So now what I will do is I will take
Actually,
out
it
this
looks
layer.
bigger than
Inverted,
5
sir. You
millimeter.
can see.
Yeah, you can see that color. So yeah, whenever I am demonstrating right to left shunt across AST, I invert the color and then see, because eyes will catch red more than the blue. It's a practical point. I don't think it's recommended to do that, but my approach is that. But no, your blue color will, with the background of a block, you cannot see properly. With the background of black, you can see red color properly. That's why invert color there if you want to demonstrate right to left shunt.
Sir, as Dr. Jayarangnath was saying,
Actually,
that the
Nageshwar,
conventional approach
you
for
are
this
you are
case-
talking some yeah, conventional approach.
Would
I mean,
be
a
a
traditional
bleeding length.
pediatric cardiologist will immediately think about 1.5 ventricle repair.
Yes, sir.
Now, does not mean every patient whose right ventricle should be condemned as only suitable for 1.5 ventricle
Yes, sir,
repair.
got that. So
There should
now,
be a way of analyzing.
I'm saying if there are additional
No,
defects.
now we have not done anything.
Yeah, absolutely. So
No,
if there are additional defects,
we have to go and properly cross.
right.
Let us now try to cross it correctly. That is right atrial appendage. And again come back. This Malin sheath is directing me away. Let me go back again to the superior vena cava. I'm coming down. Okay. Now give me that balloon, the same balloon. Oh, this is a non-exchange wire. So I want an exchange wire here.
Sir, this one. Philips can be sent. That machine can be sent. That machine can be sent to OPD.
Pramod, am I through that?
Yes, sir. I'm looking
Okay.
into it, sir. Now we are actually across this. Yes.
You are holding?
Who is asking?
Because he demonstrated thoracic subsified view nicely, he went through another perforation. That's why they are not using TE. It is fairly okay because you can see the image quality is very good. Earlier we had doubt about additional, but upon redoing the echocardiogram, they found it is gone through some other. So I think this is very good. There is no. Let them.
So now the ASD is clearly shown,
Yes.
and possibly my wire is going through that.
Unless you put a balloon. Yeah, yeah. It's nicely
Yes.
seen.
Hold it. Hold the wire.
That is true. Tie-sack balloon is a. Yeah. But they are inflating in such a way that just to get the indentation, not to dilate that. Ideally, you need to have the sizing balloon, but 24 is going to be big for this. And probably 18 shortage is there. Amp-larger 18 shortage is there. Amp-larger 18 by abort, which is not freely available. So the next balloon is the tie-sack only is better. Because remaining balloons are much more non-compliant than tie-sack.
Of course, sir. First.
Yeah, you are across the so-called wide foramina or small AST. Yeah. Now we will
Yeah.
do the bubble contrast.
Again, okay. Yes, but now I am less optimistic because I know that there is possibly another orifice through which I had crossed. Now the question will be, we probably have to cross through the second orifice also. Let me now
Why
try
don't you
one.
just do bubble contrast and then see? Because okay, still there.
Make it little darker, Pramod. Eye
Yeah.
scan.
Yes, sir.
Yeah, the saturation is not increasing.
Sir, can you do like put a device and just check RA pressure if suppose that device flanges of device may
Correct.
occlude because
Correct.
two SDs are looking very close to each other.
In fact, I am going to do that now. The probably now that we have this is what is this balloon size? This is what is this balloon?
Now if you
12.
put a
Okay.
color, I
Give
think
me
I am seeing an inferior where the IVC is joining. It appears that there is a small hole is there. Okay.
Even in
Dr.
the region
Sushil
of
is
the
telling
fossa
that
vallis,
close to
there seems to be
SVC.
some SVC. There is a color flow, probably adjacent to my balloon, right, Pramod?
Yes, sir. It's adjacent
So
to the balloon.
it
So
may be
should
possible that it is a sort of there are few fenestrations in that area.
Yes. Yes. Now
We will what we will do is, see, the RA pressure is not increasing. We will just put in a 14 millimeter device and see. I am hearing the bell. Prabhu, what is the recommended sheath for a LifeTech 12 mm and a 14 mm? Just see it and tell.
How much did the RA pressure go up to after occlusion, sir?
It did not go up at all. It is remaining around 6 to 7.
Oh.
It's not increasing at all because I am not occluding. I am not completely occluding. It remains at the same 6 to 12 continuously.
And the saturations also?
9 means I have only 8 here, right?
Saturations
Saturation did not increase because saturation is also not increasing. So what I am going to do is do a very quick test occlusion with a device and see what is the effect of the device on the RA pressure as well on the saturation. So now the show me the Prabhu, get me a LifeTech 12 millimeter device and a 14 millimeter device. Let me decide. 14 should be what is the LA disc size?
But what is
24,
the balloon
26,
is
right? This is a 14.
Shiva, your balloon is 10, right?
Balloon is 12. 12.
12 balloon, and I
12,
don't
12.
see any constriction. I don't see any constriction. So
No.
I am
Yes.
actually
So
worried
I'm
about
assuming
12.
it's 14.
I am worried about 12 device actually. It's that whenever there is a right to left shunt, your RA disc is smaller than the LA disc. So it acts like a foramen well. So
Yeah,
you
I
need to
agree.
oversize actually. You
Yeah.
cannot put a 12 millimeter because right atrial pressures are higher than the
I'm
left
going with a
atrial
14. I'm going with a 14. Nageshwar.
Yeah.
So we are presuming it will close both the defects.
That's what we are hoping.
Actually, what we'll do is, after putting the device, let us see what is the saturation. Being a very porous device, it may not close immediately, but definitely there should be an improvement in the saturation.
The coordinator is insisting us to stop, but we are also equally interested in the case. So that's why we requested him 2 more minutes.
Actually,
he kindly agreed.
Nageshwar, I have a live in the box, and so I can cut down on the time there.
But this is much more challenging and interesting actually. So let's do that 2 minutes we
That's
have.
right.
Right?
Oh, no, what I'm telling is I can cut down on that live in the box session so that this is far more like thought provoking.
Can we focus on the
Very
fluoro
educative,
image?
sir.
Fluoro big. Get echo, Pramod. So
Yeah,
now
that's nicely
show
rapidly
echo
deployed.
image and and hemodynamic big. I am now looking slowly at the saturations. What is happening? RA pressure is not increasing. Show the
So A wave, what was the beginning A wave and the present A wave?
it's small. It's not very high, Nageshwar. It's looking very benign now. The
So
RA,
can you give
RA is not
contrast
looking high.
echo now?
Now I'm
Can you give contrast echo now?
Yeah, I'm just waiting for some saturation to increase, because the problem is this is a porous device. The porous device may not immediately close also. But anyhow, I'm giving the contrast now.
Yeah, I agree with you. I think what
coming up.
Shiva is planning to do is let us close the defect, whatever maximum possible, we'll close it. Because the saturation, not saturation, the hemodynamics did not increase afterwards. Probably that is what in mind. Because the right ventricle appears reasonable, it is even though borderline, the tricuspidal G score is more than minus 1.5. 0.25. So it's a purely a diastolic dysfunction. Suppose, imagine a hypothetical situation, we closed the device. Then what are the consequences? The consequences may be child may develop puffiness of face, progressively some edema and all. So anyway, in these cases, you are thinking to do 1.5 ventricular repair. That is a Glenn and leave the antegrade flow will be there, IVC, and close the AST. So now you are staging it. You are closing the AST, and then probably you can consider Glenn also. Because you are not getting the hemodynamics properly. Child cannot live with the saturation of lesser than 85% and all in a normal ABBA concordance with borderline RV. So I am going to agree the steps which are done in this particular case. Probably your RA disc is pulling and the defect is getting opened, the superior defect close to the SCT. Even though you are not demonstrating properly by the
Yeah.
echocardiogram, your contrast indirectly is suggesting that.
Actually, one more thing I will show. Show the child's face close by. He has gone into a deep sleep and he's snoring a lot. You can see the RA mean pressure flinging up and down. Show the RA mean pressure now, bigger. RA mean bigger. See the amount of respiratory compromise. The child is now like see the amount of snoring and all because of the sedation. Now that is also possibly not allowing the saturations to significantly improve. I agree with you, Nageshwar. I will wait for another half an hour here. I will look at what is the saturation and then take a decision about whether to release or not if the patient is fully heparinized. I'm losing the audio.
No, the questions are to evaluate for the other shunts from the floor. Yeah, I told actually you must have evaluated or probably we need to evaluate. Yeah, that probably they will consider
other
that
shunts at the
because
level of
Contrast
other
is going
shunts at
from
the
RA
level
to
of
LA.
like a PAVM. Contrast is going from RA to LA. Yeah. In fact, if you remember,
no,
Sushil, I went in through another inferior fenestration.
Filling from RA to LA. So it has to be intrathecal communication.
Yes.
No other communication.
And also he is giving a sheath injection.
Yeah. Another thing is I went in through
So
an inferior
everybody is
perforation and I
suggesting
had
to do
stretched a 12 millimeter
transesophageal
balloon.
echocardiogram.
Yeah, we will get it done because the time is running out.
What
I
about-
will stay here. Probably on the next opportunity when we all meet, I will explain to you what happened.
What about giving a thought of intubating for a time being so that respiratory variation will come down and that will give more confidence in decision making, sir?
The basically what we need to now look at is whether how many more additional fenestrations are there and how far away from my device are they. Obviously, if there are devices that are in the circumference of the atrial septum which is not getting closed by this particular device. This is a 14 mm device, right? 14 mm device, what is the LA disc? 26.
26, yeah.
26 or 28?
26. Will be
26.
26.
So maybe, yeah, maybe a 26, a 25 PFO device or a 30 PFO device may be able to close far better than this particular device because this device RA disc is smaller. So, I mean, as Nageshwar pointed out, the flow is from RA to LA and we need to have a little larger RA disc. I'm going to now possibly look at the anatomy much more closely, leave the device for some time and see what is the saturations.
Cribriform
And I
device
will be
also you can consider.
thinking about changing it into either a cribriform or a PFO device which will have something like around 25 to 30 millimeter disc on the RA side and see what is the impact on the saturations. RA pressure is not significantly increasing, RV seems to be adequate. So our next plan will be to probably change the device into a device which has got RA disc being larger, either probably a cribriform device or a PFO device.
Yes, sir, I think only when we achieve complete occlusion of the ASD will the purpose of the procedure be accomplished. So I think that's a way to go.
Exactly. If there is an incomplete closure and the saturation continues to be low with persistent intraatrial communications, it's not worth it.
Yes, sir.
So I will work for completing the closure. I have to make some more changes in the type of devices.
Yes, sir. Great case, sir. A lot of learning.
Nice hemodynamics, sir. Thank you.
A
so
very
much.
new way to approach this borderline RV cases and to be done very systematically with all the hemodynamics and everything, having proven all that, then going ahead is the right way. Absolutely. Thank you very much for this, sir.
Thanks a lot, and we will keep you posted what is happening.
Sure, sir. Thank you.
Thank you, sure.
I would like to know from the chairpersons, would you like to hear that live in the box, or would you like to have more discussions till 1 o'clock?
We have finished our cases,
There is a
presentations here.
Yeah, we don't have any pending presentation
so-
as of
so
now.
there-
We
there
can
is a-
continue, I think. Yeah.
Okay, so then shall we go ahead with the live in the box presentation now? Give me a minute and I will be there.
Not
This is
increasing.
the RA pressure. Now he has removed that.
We have put a new 25 mm cribriform device.
What Pramod has done is he has put in a 25 millimeter cribriform device.
Yeah.
Now his saturation is right now around 92% on the pulse oximeter. Show that.
Yes, we can see that
Okay,
93%. Yes.
He 92, 93. And now let us now have a look at the contrast echo about how much of right to left shunt is currently there and how the device looks on the fluoroscopy, on the echocardiography. Yeah. So this is what he has done is a 25 millimeter cribriform AST device. Show in LAO projection the cribriform device. LAO. Full LAO. Keep on doing LAO. Do an LAO. Yeah. Make this picture bigger. I don't know what they are seeing now. That
Yeah, we
picture
can
has
see
gone
that.
blank.
Yeah, we can see that.
Yeah, are you able to see the screen? Okay. So now get me some contrast here. No, I'm not. I'm giving iodinated contrast. I'll just show the orientation of this RA disc. Can you go cranial now? Give the contrast quick. Go cranial. Yeah, good. Now
Yeah, it is
okay.
nicely
Now
complete
show me
obliteration, I think it is.
Yeah, show me on.
Can we see the
No,
echo?
but this is contrast, Bhavesh. So I will try to show the echo now. We are
Yeah,
now going
yeah.
to give
Because there is
contrast
some
echocardiography.
contrast is going.
Come to AP. Yeah, come to AP. Make the echo big. Okay.
Yes, we can see that.
Now,
Yeah, very minute amount of
Drastically come
contrast
down.
is going, I think.
It
it
is
is
there,
still
but
there.
it is significantly
The only
less
thing
than
is the
before.
saturation has slightly. Yeah. Now, show this hemodynamics there. Now this is the RA mean pressure with a saturation of around 93%, and RA A waves are around 10 millimeters. RA mean is around 7 millimeters. Probably, Bhavesh, I will wait for another half an hour more.
Yeah, I can.
I will stay here,
Shiva.
and
Dr. Shiva.
probably we will try to see what is. Yep.
Yeah.
Yep.
Yeah. Thank you, Shiva. Thank you
Thank
for
you
the
very
nice
much, sir.
demonstration. So we are
Sir, thank
concluding
you
this
so much.
session right now.
Yeah. Sushil was about to tell something.
So actually, Neeraj is waiting for a webinar, but I don't think so we'll be able to do that because it's almost 1 now.
Okay. Okay.
Thank you so much,
I
sir.
thank
Thank
each
you.
one of you, Dr. Bhavesh, Jai Ranganath, Nageshwar, all of you, Sushil, Prashant, each one of you for having made this session so lively and so interactive, and it was a pleasure. I wish for a day when we meet all of us,
Thank you
all
so
in
much,
person.
sir. It was a pleasure
Thank you
for
very
us.
much,
Thank you.
sir. It was a great case.
I also want to thank all my entire hospital for the support. Here with me is Alka and the team of people who are all working today, and each one of them were significantly supportive, and it's a nice opportunity to hear all of you friends, even at a distance, to hear your voice and answer back you. It's always a pleasure.
Yeah. Thank you, Dr. Shiva.
Echo big.
Thank you, sir.
Yep.
Thank you, sir.
Thank you very much.